when to advise your patient to go for early radiotherapy or to defer, wait until there is rising PSA. So we call the early implementation direct adjuvant radiotherapy, and the radiotherapy which is implemented because there is rising PSA or there is an MRI evidence of a disease relapse, this is called salvage radiotherapy. And we'll see the difference between early adjuvant and salvage, and if we are using the salvage component, then again we have to use the early salvage. You don't wait until patient is more and more having gross disease. Okay? So this is post-operative. Yes. He is candidate on the adjuvant basis, but you have to sit with your patient, as I'm going to say, and tell him what is the pros and cons. Okay? So the fourth, post-operative therapy versus salvage. We're going to speak about the prognostic factors, patient selection, okay, and the toxicity. Whether to start adjuvant radiation therapy early or salvage, and we see that the early complication is higher with the salvage rather than the adjuvant, and the late complications also will be shown. And the dose, the treatment volume, whether it's going to be tumor bed or you want to delineate pelvic lymph nodes or give a mini pelvis. And finally, we're going to show some pictures. Okay, so these are the topics that are going to be covered. So the salvage radiotherapy significantly reduced the incidence of local recurrence, but there are some studies that said there is no effect on the mortality. Factors associated with improved biochemical relapse-free survival after salvage radiation, the positive margin, low PSA level at recurrence, and long recurrence-free interval between the surgery and the implementation of radiotherapy. The short, less than 6 months PSA doubling time and a high Gleason and a positive lymph nodes or seminal vesicle infiltration initial diagnosis carry a worse prognosis. So we have to select patients for when to implement adjuvant radiation therapy. Adjuvant radiation should be offered to patients, but not highly recommended. It should be offered to patients after prostatectomy with an SVI, safety margin positive, or extracapsular extension. And the multidisciplinary team, with full consideration of the patient's history, values, preference, quality of life, and functional status, should take this in consideration prior to using the adjuvant context. This is a nomogram, which is quoted from the UpToDate, that you can, based on the surgical margin, the pathological Gleason score, pathological stage initially, pre-radiotherapy PSA, you have a total point. And with this nomogram, for each point you click here, and then finally the total points is down there, and this is the 5-year biochemical relapse probability. So the higher the Gleason, the higher PSA, the pathological stage higher, carries a worse biochemical relapse being survived. So this is the issues has to be considered when you are putting your patient in the basket of adjuvant radiation therapy or salvage radiation therapy post-prostatectomy. So the dose radiotherapy should be at least 64, at least, not less, 64 or higher. And there's also some studies that are differentiating between giving an adjuvant on an NED basis because of rising PSA, or there is a patient who came to you with a gross residual. So 64 with a gross residual will not be enough. So you can go as high as 70. Okay, so this is the debate between the salvage and the adjuvant radiation therapy. No standard role adjuvant systemic treatment for rising PSA values after prostatectomy. The 5-year PSA remission rate after salvage radiotherapy ranges from 27 to 45%. Okay? Radiotherapy should be limited to the prostate bed. This is a suggestion and a recommendation because we'll show that there is still an ongoing trial that is trying to answer this question. Whether you want to give localized to the prostate bed or you want to include the mini pelvis, there is an ongoing trial. The RTC showed the improvement in biochemical relapse-free survival, but not overall survival at 10 years. The improvement of the SWOG in the both metastasis-free and overall survival, but the RTOG and the GUTEC failed to show an improvement in survival for prostate plus lymph node radiotherapy compared to limited prostate bed only. So this is the only randomized trial that showed that the addition of pelvic lymph node in the adjuvant setting is not of benefit. And hence, the RTOG 053, and this is the name of the trial, it's quoted from the RTOG website. They are questioning the effect of elective pelvic irradiation in patients with a rising PSA following surgery is being addressed in an ongoing multicenter trial. Here is the only cohort is a rising PSA. Not a safety margin positive, not a lymph node positive, not. Only based on rising PSA. So the toxicity, salvage radiation after radical prostatectomy is generally well tolerated, with increase in mild to moderate urinary symptoms and incontinence. In one institution database, the 81% of the patients were salvage radiation and 19 as adjuvant therapy. So this is an institution with 1,000 patients. So the concept of salvage was there in that institution and not the concept of adjuvant. The 5-year rate of grade 3 toxicity was less than 1%. Okay? Any question here? I can change the laptop and you can